Good afternoon, ladies and gentlemen. We'd like to start the next session. Before starting, there are the housekeeping announcement. One, the QA session will be held at the second half of the session. And we will be delighted to have online participants comment and questions during and after the speaker's presentation. Please remember using Q&A function for writing questions and comments, not chat box. The second one is we are going to record these satellite sessions and upload the video on the YouTube channel of JICA Ogata Research Institute later. So please understand that this is going to be recorded. And the third one, now is the lunchtime. So the outside lunch box is ready. So if you haven't get one, please take it as you like. So the housekeeping announcement is finished. So ladies and gentlemen, again, thank you very much for coming to this JICA Satellite Session. This session is about Global Health 2050. That is a Lancet Commission's report, the newly published. It was published during last month. And we are very much honored to have the commissioners as a speaker and have esteemed commentators for the discussion. So I hope you could enjoy the discussion and you can have a very actively participate in the session. I'm Saida Makimoto from JICA, and I also participated as a commissioner to the Lancet Commission. So that's why JICA organized this session. Maybe some of you are wondering why JICA is organizing this session. So I just want to share the background. And if you haven't seen the document, you can take the QR code, this one, or you can just Google the Global Health 2050 and you can access to the document. Today's agenda. At first, we will have the presentation on Global Health 2050 report. There are 4 presenters. Then we have a panel discussion, and including Q&A with the floor. So these are the speakers of today. The first, I'd like to invite Dr. David Watkins to give us the summary and the 7 key messages of the Global Health 2050.
Welcome everyone to this session. We're very excited for you all to be here. I am serving both as the introducer of the Commission report and as the moderator of the discussion. And so I'm very excited to be both opening up the discussion today and also presenting right now just a brief summary before we get into the meat of the session, which is 3 presentations on the technical aspects of the report. So Global Health 2050, a bit of background, was commissioned by the Lancet starting in early 2023 is after recognition that the global health agenda seems to be a bit adrift after the pandemic. There's burnout, there's malaise, there's not a lot of interest in governments on health now. People have kind of moved on, and so the idea from the Lancet was to prepare this report to have some sort of optimistic, positive, actionable messages to really get the global health agenda back on track. So Global Health 2050 is built around this Lancet Commission on Investing in Health, which started in 2012 as the intersection of health and economics, really oriented around the messages you would give if you're a health advocate to people who work in finance and development more generally. And it's led by 2 respected economists in the field, Larry Summers and Dean Jamieson. And the report is a product of discussion and debate for about a year amongst commissioners and advisors. We produce analyses for the world and generic messages for countries irrespective of income or region. But an important thing to know about this report is first and foremost, it's not a prescription of what to do in any one particular country. It's a framework to help think about how you might achieve better health in the coming 2.5 decades. It's not a comprehensive report either. It's meant to be a summary of the things we think are missing from the global health discourse, but it's certainly more can be said in some areas, and others are saying that. And of course, it's not meant to be the final say on what the global health agenda is going forward, but rather a starting point for discussion in the international health community and, most importantly, within national governments. So the first key message of the report is that nations that choose to do so can achieve what we call 50 by 50. And 50 by 50 is the idea that we can reduce the chance of dying before the age of 70 by 50% by 2050 relative to 2019, i.e. just before the pandemic. And this is based on looking at historical trends in some countries that have performed very well over the past 3 or 4 decades, such as Iran, such as Bangladesh, Turkey, and other places that have seen dramatic reductions in mortality. And those countries have achieved reductions at all different levels of income. So you don't have to be a wealthy country to achieve this level of health gain. And so you can see here the plots from trends over the past couple of decades for regions, but you see countries within those regions that are going down faster. And those are what we call the exemplar countries that have managed to achieve better health at low cost. So 50 by 50 is meant to be a rallying cry for achieving better health at the national level. The second message, which is closely related to the first, is that countries that choose to do so need to focus on reducing mortality and disability among 15 priority conditions. Now, there's thousands and thousands of health conditions out there, diseases and injuries, but really, by focusing on a few things that are major causes of disease burden, you can achieve a lot of results without getting, as it were, distracted by a lot of other health issues. And so this idea of remaining focused is really central to throughout the report, because what we've seen in the global health discourse is a lot of incoherence and struggle to really kind of like come around some sort of common goals. And so we argue for focus. We argue for really sharply focusing on a few conditions. And this is, again, based on evidence that suggests that most of the difference in life expectancy between the countries that are doing the best and the countries that are not doing the best can be attributed to about 15 different clusters of conditions. And we group them, roughly speaking, into 8 that are infectious disease and maternal health conditions. You can see the specific ones listed here. And then 7 clusters of NCD and injury conditions. And this plot over here on the left shows that in all the world regions, the x-axis here is the difference in life expectancy between the North Atlantic region, the region with the highest life expectancy, and other regions. And you can see the colored bars show the proportion of that gap that's due to the 8 infectious and maternal health conditions in green and the 7 NCD and injury-related conditions in blue. And they account for about 75% of the difference in life expectancy. And so a fairly small set of conditions account for most of the differences, most of the inequalities in life expectancy around the world. And we argue to really focus on these conditions going forward. The third message, which builds on the second one, is that the UHC agenda and the health system strengthening agenda, which is part of this conference, right, is in desperate need of a reset. Their UHC's become everything for everybody. It's become a vague goal, and countries are really struggling to achieve UHC, particularly since it was adopted as a goal within the SDGs. So what we propose is to think about what we call a modular approach to health system strengthening on the path to UHC, which, if you think about it, is really related to this idea of diagonalization that was proposed many years ago by Julio Frank and Jaime Sepulveda, which is that you can use disease-specific thinking to really push the health system development agenda forward. We specifically build on that by saying, analytically, how you think about prioritizing depends on, 1, setting a general direction for the health system by allocating budgets across different, what we call modules or disease groups or delivery systems, and then thinking about how you would optimize the set of interventions within each of those groups around criteria like value for money, equity, financial protection. And by doing this, you maintain focus on priority conditions while also advancing the health system development agenda. The fourth message is about medicines, which of course is a topic that I'm sure in this conference will get a lot of discussion. What we say is that countries need to focus on a short list of key medicines around 15 priority conditions. And we specifically propose one mechanism for doing so, the Arrow mechanism, which is named after the late Nobel winning prize economist Ken Arrow, who was also a member of the original commission 10 years ago. And the Arrow mechanism was used for malaria very effectively about a decade ago before the program was shut down. But the components of this mechanism are, number 1, basically redirecting the budget transfers that go to ministries of health to line item budget transfers for specific drugs. So there's a clear budget line for antimalarials, antihypertensives, and so on. 2, centralized pooled procurement, either at the national level or within groups of countries, like at the regional level for smaller countries, which can dramatically reduce prices for drugs. 3, procurement in large enough volumes to ensure availability, and this is related to the pool procurement mechanism. So there's a steady supply of drugs and a steady commitment to manufacturers to get those drugs in large volumes, with the trade-off being lower margins but higher volumes produced by manufacturers. And the 4th is to use and strengthen public and private supply chains. And the private supply chains are especially important here because if you can effectively subsidize drugs in the private sector, you can solve this problem of out-of-pocket costs, at least for priority conditions, because we all know out-of-pocket costs on drugs are a major driver of financial hardship. And what we saw with malaria is that those out-of-pocket costs went way down when this mechanism was implemented. And so we say we learned from malaria how to do this. We need to expand it and push it to other priority conditions. The 5th message is that tobacco is the new tobacco. We all hear that, obesity is the new tobacco or whatever is the new tobacco. We say tobacco is the new tobacco because there's still way too many smokers in the world. And raising taxes on tobacco is probably the single most important public health and public policy intervention out there. But there are other fiscal measures too that finance ministers need to be aware of. One that's really big and is an emerging issue is thinking about removing subsidies for fossil fuels, which in many countries is a major drain on government budgets and a harm to climate. And the other is thinking about starting to tax unhealthy food and drinks and other products, because this is a major driver of what we're seeing now is a chronic disease epidemic that is no longer constrained to the rich world, but every country is facing. So these sorts of fiscal policies are a major contributor to health, and tobacco is the first stop on that train. 6th message is that there's a very high risk of a pandemic of COVID-19-like magnitude or greater. A work that was done by the Commission, by Friends of the Commission, showed that essentially over the next 10 years, the chance of another COVID-like pandemic is probably 1 in 4. And if you extend that out to 2050, it's probably 1 out of 2. And bigger and more catastrophic pandemics are also possible, as you see from this table. But even smaller pandemics are likely to show up within the next few years, and we need to be prepared. On average, the expected annual losses from pandemics would be about 2.5 million deaths per year over the next decade. That's about 1.6 million from the influenza pandemic and 0.9 from coronavirus. Obviously, most years that number is 0 until it becomes very high, but the expected average annual losses is considerable. And this is about as many deaths out there as there are from HIV, TB, and malaria combined. So this is not a small amount of potential mortality. The 7th message is that the development assistance community has a crucial role to play in supporting 50 by 50 as part of its rethink of what it's doing. And we propose 2 broad purposes for development assistance. The first is direct country support, which is most of what development assistance does now. But we say that development assistance needs to be refocused on the very poorest countries, rather than being generic support for countries mostly on political considerations. Really focus direct country support on the countries that need it the most and get out of the business for countries that don't need it. And most of development assistance actually should be supporting collective action and public goods. So for example, reducing antimicrobial resistance, pandemic prevention and response, development of new tools, drugs, diagnostics, and so on. And again, development assistance would need to be reoriented around those 15 priority conditions to assure the highest health impact. So here's a link to the website for the report. There's also the QR code, which you saw at the beginning and will show up at the end. Here's a nice screenshot, and here's a summary of these 7 messages. We'll pivot now to the next 3 presentations, starting with Sarah Bolengaita to talk about priority health conditions. Thanks.
Thank you, David. Okay, so my name is Sarah Bolengaita. I am a PhD research fellow at the University of Bergen in Norway. And I am a member of the Lancet Commission on Investing in Health, and I was responsible for a lot of the analyses that were underpinning the report. So over the next 10 minutes, I'll discuss the first 2 key messages that David went over. So this will be the 50 by 50 goal and the 15 priority conditions. So 50 by 50 is our shorthand way of talking about this goal, which is a 50% reduction in premature death by the year 2050. And this premature death, what we mean by that is the probability of premature death before age 70. And so in this graph here, we have the probability of premature death, or PPD, for the world from 1970 to 2019. And you can see that in 2019, before the COVID pandemic, the average person in the world had about a 30% risk of dying before age 70. If the 50 by 50 goal is achieved, the average person in 2050 would have about a 15% risk of dying before age 70. And to put that number into context, that is the current level, the current probability of premature death of the North Atlantic region, which is a combination of Western Europe and Canada. So the frontier best performing region that we analyzed. So it's clearly an ambitious goal, right? But is it feasible? So when we were trying to assess the feasibility of this goal, we looked into the past and we assessed countries' probability of premature death performance over the past several decades from 1970. And we saw that 37 countries were actually able to achieve this 50% reduction in PPD in a 31-year period, which is the time frame of the 50 by 50 goal. And importantly, we saw that starting level of PPD, so the level of mortality, was not important here. Countries were able to do this 50% reduction regardless of their starting level of mortality. So we can see Vietnam here, for example, is the yellow line. In the early 1970s, they had about a 66% probability of premature death. By the mid-1990s, this had dropped in half to about 33%. We also look at Italy, for example, which had a lower starting level of PPD, about 30% in the mid-1980s, and this reduced to about 15% in the early 2010s. So this is something that's achievable for all countries. We also tried to take a look at current rates of improvement. So looking at the rate of improvement and the probability of premature death in 2010 to 2019. And in order for countries to achieve the 50 by 50 goal, they have to have an average rate of improvement of 2.2% or better. It doesn't matter what your starting level of PPD is, just the way that the math works out, you just have to have an average rate of improvement of 2.2% or better. And we saw that 7 of the 30 most populous countries already have that level or better. And we can see that this spans the income group classification. So there's Ethiopia and there's also South Korea in this group of high performing countries. We also saw that there's 14 countries of the 30 most populous countries that have a rate of improvement between 1% and 2.2%. And this translates to an implied reduction in PPD by 2050 of somewhere between 25 and 50%. So these countries need to do some additional effort in order to accelerate declines in mortality, but it still feels like a feasible goal. However, there are some countries that are faltering. So these 9 countries are, of the 30 most populous countries, have rates of improvement lower than 1%, meaning that by 2050, the reduction in PPD will be less than 25%. And the US is a particularly poor performer in this group. You can see that actually the US, if it were to stay the course that it's on, its probability of premature death would actually increase by 2050. So that the US has a lot of work that needs to be done in order to achieve the 50 by 50 goal. So we've talked a lot about mortality here with the 50 by 50 goal, but we know that that's not the whole picture, right? So what about morbidity? What about disability? The way that we were thinking about it was we thought about life expectancy and about health-adjusted life expectancy, which is life expectancy that takes into account illness and disability. And we saw that for all countries in the world, these two measures are highly correlated. So life expectancy here is the red line, health-adjusted life expectancy is the blue line, and you can see that there is a strong relationship between the two. So our thinking in GH2050 is that if you focus interventions and investments on reducing mortality, you will also at the same time reduce morbidity. And so not only will populations be living longer, but they'll also be living healthier. Okay, so how do we achieve this 50 by 50 goal? Our message is to focus. You have to focus on key conditions that cause the majority of mortality. So we identified 15 conditions 8 infectious and maternal health conditions and 7 NCD and injury-related conditions that countries can prioritize in order to accelerate mortality declines and achieve that 50 by 50 goal. David already presented this graph, but I'll kind of break it down a little bit more. So in order to assess these priority conditions, we looked at the gap in life expectancy in world regions compared to the North Atlantic region, which is our best performing region. And again, that's Western Europe and Canada combined. And we can see here, if we take sub-Saharan Africa, which is the bar at the top, there's a 22-year gap in life expectancy in sub-Saharan Africa compared to the North Atlantic. And about 16 years of that gap is due to the priority conditions, and that's about 75%. And we can see that that remains true for all regions, how important these priority conditions are in the gap in life expectancy. We also wanted to think about life expectancy gains. So how have countries achieved life expectancy gains, and how do the 15 priority conditions fit in here? And so in this table, we see the gains in life expectancy due to the 15 priority conditions, or due to reductions in mortality to the 15 priority conditions from 2000 to 2019. And if we just look here in the first column for the world, there was about a 6.5-year increase in life expectancy over this period. And we can see that the 8 infectious and maternal health conditions contributed 3.7 years of that gain, which is almost 60% of the gain. The NCD and injury-related priority conditions contributed about 30%. So these collectively are very important. They make up almost 85% of the gains. And if we think about it from the other direction, other causes, they contributed less than 1 year of gains in life expectancy, about 14% of total gains in life expectancy. All the other conditions that are not the 15 priority conditions, right? So that kind of says a lot about how important these 15 are. So in conclusion, 50 by 50 is a main goal presented in the report. It refers to this goal of a 50% reduction in the probability of premature death, or death before age 70, by the year 2050. And we argue that 50 by 50 is feasible. We've seen countries do it in the past historically, and we've seen that several countries already have levels of PPD reduction that make them on track to achieve this goal. However, the majority of countries will require additional investment in order to meet this goal. And how can they target this investment? By focusing on the 15 priority conditions that cause the majority of the gap in life expectancy that we're currently seeing, and the 15 priority conditions that have had reductions in mortality that have contributed the most to life expectancy gains over the past 20 years. With that, I will now turn things over to Dr. Wenwei Mao, who will talk about how to operationalize focusing these things in the health system and how health financing can play a role.
Thank you, Sarah. So as Sarah has shared a very positive message that the 50 by 50 agenda is feasible, she also highlighted the importance of the 15 priority conditions. So now let's focus on NCDs and discuss how our health system and the financing strategy can respond and tackle these priority conditions. Again, this is the most favorable feature of today. But what I want to highlight here, I add another layer, that's the comparison between 2000 and 2019. Taking the North Atlantic countries as frontier, this figure presented the life expectancy gaps attributable to different disease. What I want to highlight here is the difference between these 2 years. Yes, most countries and regions have made impressive progress and narrowed the life expectancy gaps, meaning our efforts in control the infectious disease and the maternal conditions are quite effective. However, if we look at the life expectancy gaps accountable for NCDs, which are blue bars here, little progress have been made almost across all regions in the past 2 decades. Therefore, we need innovations in health system and finance to address the NCD burdens. Another area we made limited progress is, unfortunately, the health financing. So despite the global spending on health reached a new high level of $10 trillion in 2021, millions of people still lack of access to basic health services. There is little progress in the health service coverage, And while the catastrophic health expenditure is even more common since 2015. Taken together, there is a need to reset the UHC and the health system strengthening agenda. At the country level, there are additional challenges such as limited physical spaces or prioritization on health, insufficient capacity in resource mobilization and the budget execution, and the fragmentation in health system and the service delivery, leading to low efficiency and equity concern, is one of the biggest barriers of government to implement the strategic purchasing and get the most out of their health budget. This is an example from Ethiopia. You can see the public sources account less than a third of total financing has been allocated to government budget, the community-based health insurance, and other areas. And the government budget, along with sources from external donors, has then been used for different vertical programs. There is limited pooling of funds and a lack of coordination or risk sharing across population or disease burden. Looking ahead, changes in fertility and mortality rate have substantially reshaped the demographics in most countries. These figures show that many regions are expecting more deaths per 1,000 working age population. Such demographic headwind would also have long-term implications on health system and finance. The world is expecting a surge in healthcare demand from the increasing aging population in the coming decades, but the major contributor to the tax base won't grow much. To cope with these challenges, countries have to improve domestic resource mobilization and explore all possible financing options, including a blend of general revenue taxation and mandatory social health insurance. As David already gave a flavor of that, we propose a new tool, the modular approach to health system strengthening, and that would enable building out from an initial focus on the 50 by 50 goal to allow for advancement towards more comprehensive UHC over time. And the key is to focus on the 15 priority conditions. So it will take 2 stages. Stage 1 is to identify the modules appropriate to the local health sector and the budget arrangements. It is equally important to address the priority conditions and the other demands on health system. So examples of priority condition modules include routine immunization, cancer care, and example of health system interventions are family planning, public health functions. So modules should be identified based on country's disease burden, health system characters, and preferences. And we are not advocating for more vertical programs. Rather, grouping this intervention with similar target population, delivery channels, and technical areas make it feasible for planning and implementation. Once the modules are determined, we can move to stage 2, where technical evidence on the cost effectiveness of intervention should be applied to optimize the intervention mix within each module. And the choice of module would vary by country and over time, depending on the country context. And the different modules can be expanded at different rates in response to demographic and the system changes. So we ground the 50 by 50 agenda goal as a domestic health agenda, which should primarily be found through the public finance, cover the entire population, and free to use at the point of care. We costed a core set of priority and health system modules to inform policy decisions. To achieve the 50 by 50 goal, it will cost an additional 1% of GDP in low-income countries and an additional 2% of GDP in lower middle-income countries to scale up the intervention to cover all population by 2050. This estimate indicates that the government health expenditure will need to at least double. And what more important is, nearly all the additional spending need to be redirected towards the priority conditions and interventions. The development assistance will remain critical, but only for the poorest country that cannot afford the essential package. And now let's switch gear to the drugs. As one of the most important commodities to priority interventions are yet not available or affordable to all. So this table indicated that the private health expenditure remain an overwhelming source for drugs in many countries, regardless of their income level. And NCDs, we know that usually require long-term treatment, could be one of the major drivers of high out-of-pocket payment or even the catastrophic health expenditure for household. And in light of available evidence, when the drugs are paid out of pocket, access to the priority interventions is sharply constrained. So inspired by the AMFM, and we proposed the arrow mechanism on a national government subsidy for the priority drugs and other commodities. There are 4 key components. The foundation is to redirect general budget transfer to MOH into line item budget for specific priority drugs or other essential commodities. The budget or subsidy on drugs can be used for pool procurement and quality assurance, such pooled procurement will in turn create a long-term commitment with manufacturers, which will then encourage the manufacturer to ensure a steady supply and even lower the cost of drugs. The subsidy on drugs will then enable the procurement in sufficient amount to improve the availability of drugs. And last but not least, use and strengthen of existing public and private supply chain to ensure the availability of drug to the end user. This arrow mechanism is expected to steer resources to priority interventions, improving the drug availability and reduce the out-of-pocket payment on healthcare. And one of the great features of this arrow mechanism is the implementation does not require complex financing arrangement. It can be effective in most countries that use line item budget, and it also engages the private sector in the implementation of health benefit packages. So my take-home message, similar as Sarah just mentioned, is the focus. We need to cope with the demographic challenge and increasing NCD burden. We endorse increasing government health budget, but progressively towards UHC and focusing the public finance on priority conditions is a reasonable expectation. So now let's move to the next speaker on the pandemic preparedness.
So the next speaker is Professor Hitoshi Oshitani. He is joining online. The floor is yours.
Okay, thank you very much, Ms. Aida. My name is Hitoshi Oshitani. I'm a professor at the Tokyo University Graduate School of Medicine, and I will share my screen. Can you see the screen?
Yes.
Okay. And sorry that I could not come to Nagasaki in person, but I will present the PPR, Pandemic Prevention, Preparedness and Response part of the Global Health 2050. And as David mentioned, the Global Health 2050 that was developed after the COVID-19. And the previous version of the Lancet Commission on Investment in Health was published in 2013, which also included the PPR part, but it was just a part of one section, the section 7, the essential role for international collective action. But in the new version of Lancet Commission on Investment in Health, there has the one section for PPR. The part 6, the pandemic prevention, preparedness, and response, is devoted to the pandemic, the prevention, preparedness, and response. And now the PPR part that has almost 7 full pages on various issues of the PPR. And the first table 12, summarize the excess deaths due to COVID-19. And as you all know, the COVID-19 had a devastating the health effect in almost all countries in the world. And the over 7 million deaths have been reported to WHO, but the actual number of deaths should be much higher. And now the several research groups they published the excess mortality of excess deaths, the global excess mortality data. And excess death is estimated deaths beyond what would be expected in the absence of the COVID-19. And also the P-score are often used. The P-score is excess deaths as a percentage of expected deaths, and which means that how many percent of the the excess deaths that occurred due to the COVID-19. And the total global excess deaths, they estimated is about 23 million, and more than the 3 times higher than the reported number of deaths. And the global P score is at 12%. And table 12 summarize the P score of the 30 most populous countries. And Japan, China, and some other countries are among the best in terms of the P score. And Bangladesh, Mexico, and the Russia are among the worst in terms of the P score. And there are some technical issues to estimate the excess deaths, but this is our summary of the excess deaths and the P score. And this data was already explained by David. And so the probability of the next pandemic is quite high. And we may have the pandemic that cause the more death than the COVID-19. And we need to prepare for such the devastating the pandemic in near future. And this was already also explained by David, and that there will be the 2.5 million pandemic-related deaths per year, and which is quite high. And as also David mentioned, it's similar to the deaths associated with HIV/AIDS, TB, and malaria combined. So we have the high number of expected deaths due to the pandemic in the coming decades. And so there were also the huge economic losses associated with COVID-19. And total annual financial needs estimated by WHO World Bank is much smaller than the estimated the economic loss due to COVID-19. And the pandemic cycle, the shown in this figure, is explained extensively in this the Lancet Commission report, and also the figure 12, the contents, the capacity required for each phase are described in the panel 7 of the report. And so there are many different phases. Different phases require the different capacities. And the first part is prevention. The prevention may include intervention at human-animal interface, improving animal husbandry practices and regulating the wild animal trade and so on, and strengthening the biosafety and the biosecurity, and enhancing the animal surveillance and using some new technologies. So these are the important components of prevention to prevent the next pandemic. And the preparedness, including the national pandemic, updating the national pandemic preparedness plan, stockpiling, and the adequate clinical care capacity, and so on. The important component of preparedness. The preparedness may include other components. And early response is targeting to contain or suppress the transmission when the virus or other pathogen with pandemic potential emerge. And such intervention, they may suppress or even contain such pathogen. And we need to have a better system to respond to the such new threat. But there are still some the knowledge gap, and for the public health and social measures or the non-pharmaceutical interventions, the key component of early response, because in early response phase there might be no vaccine or the drugs. So the non-pharmaceutical interventions are the key component of early response, but there are still many knowledge gaps in such interventions. And the rapid and development of affordable and sensitive and specific diagnostics is also critical for early response. And in the late response, the vaccine and the therapeutics are especially important for the late response. And vaccine are the key component in mitigating the impact in the late response of the pandemic. And equitable access to the vaccine and therapeutics is also key in mitigating the impact especially in the low middle income countries. But at the moment, the global communities are investing the more resources only on the vaccines. And vaccine, as mentioned, vaccines are important, the component of PPR, but there are many other components and other phases which requires the more resources, more investments. And but currently most of the investments are focusing on the vaccines. And there are some of the interventions are considered as a national public goods, including national preparedness plans and stockpiles and surveillance for the monitoring and the basic clinical care capacity. So these are considered as a national public goods, but some of the components of the PPR should be regarded as the global public goods, especially in the prevention and the early response part, including the intervention at the human-animal interface, mapping of public risk, and the research and the development and the equitable access to the medical countermeasures, including vaccines, and the surveillance for early warning and early response. These things should be considered as the global public goods. And this is the monthly, the peace score, the trend in selected countries, including India, United States, Italy, and Japan. And as you can see, there were the high mortality impact in early stage of the pandemic in the Western countries, including United States and Italy. And there was a huge mortality impact in the mid-2021 due to the Delta wave. And because of lack of the access to the vaccines and lack of access to the medical care, including the supply of medical oxygen. And India and some other countries had the huge mortality impact during this wave. And in Japan and China, they were one of the best countries in terms of the peace score, but we also had a high mortality impact in the later stage of the pandemic, and when we relaxed some interventions. And there are the major challenges to strengthen the global PPR system. And as you all know, we are facing to the crisis in the global solidarity. The geopolitical situations are getting worse, and there are the tension between the global south and the global north. As you all know, that there was no agreement on the PPR accord or PPR, the WHO PPR agreement during the World Health Assembly in May this year. And there is still an inadequate response to some of the emerging disease, the threats like H5N1 in the United States, and then Pox in Democratic Republic of Congo. And maintaining the momentum after the COVID-19 pandemic is also a challenge. And we need to invest more on PPR, but the global leaders are losing the interest in PPR. And this is the phrase from the new WHO independent panel report, which was published this year. The first one was published in May 2021. And so they mentioned that today the world is not investing the pandemic preparedness response at anywhere near the scale of the speed necessary. So we need to have a more investment in the pandemic the prevention, preparedness, and response. And thank you very much for your attention.
Thank you very much, Hitoshi, for your very insightful presentations. So now we are going to move the discussion part. David will serve as a moderator.
Thanks, everyone, and thanks for the presenters for interesting start to the discussion. Can I invite our distinguished panelists to come up now? There's seats in the front for you. Dr. Roge is not there. Yes, okay. Yes, come on over. We'll have you all sit in the front, and we'll ask you a few questions, but then we'll let the audience also ask some questions too. So we have 4 excellent panelists today, and I'm going to start off by asking each of them to provide some of their reflections on the reports. But first I'll have them introduce themselves. So we have on the left here Dr. Verroge from the International Health Policy Program. So I'll let them provide more formal introductions of themselves when they respond. But Ms. Rosalind from the Government of Kenya, Dr. Kumanan from Alliance for Health Policy and Systems Research, and Dr. Toshi from the Ministry of Health in Japan. So let me start with Dr. Verroge over here. So the report says that the UHC agenda is faltering in many countries. I'm curious, do you agree with that claim? Why or why not? And what do you think about the report's message that essentially countries don't have to wait on achieving UHC to achieve better health for their populations? How would you respond to those claims from your sort of position in Thailand?
These are the 4 excellent presentations, very clear. You have 7 messages. Maybe I go beyond what you pose the question to me. Message 6 is on the risk of pandemic. I just come back from 2-week negotiation as Vice Chair of the INB Bureau in the INB negotiation for a pandemic accord. I cannot agree more with the Japanese 4th presenter that the global solidarity is going down, the multilateralism is going down, nationalism is increasing. When you have President Trump and you elect him, very unpredictable that the US may withdraw from the whole negotiation, likely to be so. Then the pandemic agreement may be aborted at the end. I have very pessimistic. I was chairing until last Friday afternoon session and just fly back on that evening. Zero lack of progress. Therefore, this message 7 will be a threat to the achievement that you have posed that it is 50 by 50 is possible. I think if the next pandemic visit you within 30 years, you have a 48% probability of having 10 million dead, right? A big pandemic. And the last COVID is 24 million excess death. And the P score 12% is very alarming. That means you have 12% of the expected or projected death of if without a COVID pandemic. Therefore, a pandemic, a future pandemic, between the course of today until 2050 can be derail your achievement. So that is one risk. Second, tobacco is tobacco, a new tobacco. Don't underestimate how the industry responds to you when government introduce stringent public health measures, increase tax. They will fight back. And now the smokeless, the ends, electronic deliver, nicotine deliver cigarette is increasingly is a major pandemic in every part of the world. And how industry pay under table to your politicians, violating FCTC. There's one article that government cannot work with industry. Even in my country, a politician visit China, a manufacturer of an ends product. So that, frankly, it violates as a state party to FCTC. So do not underestimate that political interference that can derail your achievement of 50 by 50. I appreciate the arrow mechanism. We have done so during 20 years because we use the monopolistic purchasing power. Thailand, we have a bring down cataract lens by 90% of the market price when we have a national procurement. We procure ART medicine nationally. We procure stent for cardiac insertion of your stent. Therefore, I think your 50-50 require health system capacity, whereby the challenge is reiterating health workforce density from the global south to the global north through international migration. So that is another potential challenge to your achievement of 50 by 50. The health system capacity, who will deliver these services, this intervention mix, not your health workforce, your very well-trained health workforce to do prevention, public health measures, etc. I like your conceptual approach of using LE, life expectancy at birth gaps. You can use this approach to fine-tune your national priorities. In addition to 7 and 8, maybe the 7 can be not a major priority at all in your upper middle income country, Thailand. You don't have much on the left part on the 7. So you have to expand and fine-tune using the LE, what contribute to the reduction of life expectancy at birth. And then you prioritize and invest more and understand why the health system barriers towards reduction or achievement of that. On the right-hand side, you have 8 conditions that require regulatory capacity as well. Seat belt, helmet enforcement, etc. So I kind of agree more with your proposition, but I just delineate the risks of pandemic, tobacco epidemic, tobacco fighting back by the industry. And the pandemic can be very difficult. Flu will be next pandemic. H5N1 proved human case in the US, I think in Minnesota, or I don't know. And lingering MERS-CoV in the Middle East, lingering Mpox, Zika, still a major trouble. Then these are the few global challenges. Thank you.
Thanks very much, and thanks for your kind words for the Commission report, although the challenges are substantial. Ms. Rosalind, can I invite you to come up? So your job is to implement health reform in Kenya, and one of the pieces of the report was recommending some modules and interventions within those modules to address priority conditions. I'm wondering, from your perspective, how does this align with how the government of Kenya is looking at UHC reforms in its counties? Do these recommendations seem feasible? Do they align with what you're doing? What advice do you have for us, and how do we get to better implementation most of all? So please share your thoughts.
Thank you very much, David. I think I'm still reeling in shock from his comments that we are just one breath away from going through what we all went through in 2020. One of the lessons that we learned as a country, as Kenya, is that overseas development assistance is not a way to solve your health problems. And I have a very simple parallel that I like to draw. If you're married and your wife asks you, what are we having for dinner? And then you have to say, Mike, my friend, a neighbor, has gone to the market. Let's wait for him to come back, then we'll know what we're eating. That's exactly how countries that depend on overseas development assistance for their health systems behave. You are trying to put food on your table using the means, the decision, and the wherewithal of your neighbor or your friend. So as a country, as Kenya, we have tried our best. And I'm glad that when we were speaking earlier on, you talked about the Lusaka agenda. And last year, in October, our president took a leap of faith. He really got tired of feeding his family using the decision of his neighbor and friend, and signed into law 4 very monumental bills of parliament: the Primary Healthcare Act, the Social Health Authority Act, the Facility Improvement Financing Act, and the Digital Health Act. And when you look at all these, they are the acts that give us the build up to the universal healthcare. So how has our experience been? So there's always a gap, always will be a gap between legislation and implementation. And that's the phase where we are today as a country. Not to say all is lost. We began the rollout in October, and we started with the centerpiece of all these acts, and that is the Social Health Act, which has the social health, which created the Social Health Agency, where we have the Social Health Insurance Fund, emergency and critical care insurance fund, and the Primary Healthcare Fund. And so what we are trying to do is we are trying to approach health in a different way through 2 major things. One is providing, being catalytic in terms of having domestic resource mobilization for health financing. And so that is what the Facility Improvement Financing does. But the funds are drawn from the Social Health Insurance Agency. And why this is necessary is a lot of times when you make personal investment in anything, as a person, you actually pay a lot of attention to it. You're more invested in it. And as a country, we've never had that. We've never been very, very intentional about personal health insurance, especially not public health insurance. And this is the first time that we are witnessing that. Then there's also need for coherence in managing health, both outcomes, predictions. We've talked about pandemic preparedness, and Professor Istoshi talked about mapping of risk. There's no way you can map risk if you don't have data. You need data to make predictions. You need data to decide interventions. So the Digital Health Agency comes in very handy for us as a country in the drive towards, in the achievement for universal healthcare by giving us data. Previously in Kenya, we've had several health management information systems, but they've all been very, very fragmented and vertical, and most of them have been speaking to specific diseases. And my very good friend, Dr. Lilian Otiso, is here. She leads one of our agencies that leads in the fight against HIV and AIDS and HIV programming. And they have a very robust system they call the Kenya EMR. But what we are saying is, if they have been able to all these years achieve a very robust system for having data for HIV patients, for treatment, for monitoring everything, for testing and all this, why can't we apply this to all the other diseases? So that when you walk into a facility, a health facility, it's not just about having data for a specific disease, but having data all across. And this will help us because I work in the village, right down in the village. And one of the things that we experience is a very big disparity in simple things like describing symptoms. So you find a mother or an old man or an old lady who hasn't gone to school. And so sometimes they tell you they have a backache when the pain is really on the chest. Or they say it's the chest when the pain is really on the back. And then it depends on what day it is. It depends on how they feel. The next day they'll go to another facility and give a totally different description of the symptoms. And so if we don't have data that can give us a historical analysis and a historical pathway to a patient, then we are not able to have the proper diagnosis. And with that, of course, now our problems are compounded. So for us, digitization of health comes in very handy. One, for every patient to have their data, and also for patient data portability. So you can have access and you can have services at any other point. Then, of course, we have the Social Health Insurance Fund that I spoke about earlier. And this is where we have the principle of equity, achieving equity in health by contributing according to your ability, but getting assistance or getting benefits according to your need. So it's a system that's new in Kenya. Of course, it has its issues. Like everything new, it has its issues. But we are hoping that when all these issues are overcome, then we will see, we'll witness a scenario where those in employment and those with the regular incomes are able to contribute to a system that enables those who are indigent, those who are not able to pay for health insurance for themselves, to, we achieve equity so that everybody is able to access that. Of course, again, the major challenge that we have in Kenya, we continue to have, is that we have two levels of government. So the national government, which is the one responsible for legislation, policy, and quality assurance, where my very friend seated here, Dr. Liz Wangia, works, they set the rules, but we play the game. So a lot of times that becomes a bit difficult because they might set the rules in a different room with a different perspective, a different view of the field. But when we get into the game, I probably don't have shoes. Maybe they envision that I'm going to kick the ball with boots, but I don't have boots. I don't even have shoes, leave alone the right football boots. So these are some of the things that we are working at. This is some of the challenges we are facing. But basically, we are in principle united in three things. That is domestic resource mobilization for health, catalyzing that, and catalyzing coherence in data. And lastly, and very important, is primary healthcare. We have not, as a country, been very keen on preventive and promotive health. And the Primary Healthcare Act enables us now to emphasize that we already have, as a country right now, beginning October last year, a total of 107,000 community health promoters. Now, the community health promoters act as our level 1 hospital. So they live within the community. They're the people who walk into your house at any minute. They're your neighbors, the ones you see when you go to the market, when you go to fetch water from the stream, or when you're just walking in our villages, as you know, the outlay there. And so health conversations can take place anywhere, on the way to the market, as you do something else, as you meet for a social function, and so on and so forth. So we are trying, and we have tried to bring healthcare to the doorstep. We equipped them with basic needs like a glucometer, like testing for malaria, which is one of the, our very, very big disease burdens back in Kenya, and so on and so forth. And also the issue of antenatal care. So the first 1 or 2, diagnoses post just the missed menses, we have now that being taken care of by the community health promoters. And by the time a patient goes to a facility, they really, really, really need to go. The Primary Healthcare Act also ensures that now we have a referral pathway, which we didn't have before. So by the time you go to a level 4 facility, which is our higher level facility, you've been seen at the lower level facility. This does two things in terms of universal health care, coverage. One, it decongests our higher level facilities and allows our specialists to really be and remain specialists, so that every other common illness is covered at the local level. I think that is it, but I just want to say that we have political goodwill. What is remaining is now the technical implementation, and that's what we keep working towards, and that's what we keep improving. I thank you.
Thank you very much. Very, very thoughtful comments. So we're going to pivot now to research a little bit. So I'll ask Dr. Kumanan to come up and speak from the perspective of the Alliance for Health Policy and Systems Research. So the Commission presents an optimistic vision for health where health technologies and innovation will be a key part of the solution for improving better health. So we have a lot of nice things to say about R&D, but I'm wondering about health policy and health systems research. From your perspective with the Alliance, what are some of the key takeaways from the report for your agenda as an organization that supports research in low and middle income countries? And how could this report be used by the Alliance and its friends in the future? Thanks.
So, konnichiwa, and good afternoon, everyone. And it's a real pleasure. Thank you for the invitation, and the presentations were excellent. I mean, I always think these commissions, I know Gavin Yamey quite well, and I said to Gavin, the way you do these commissions, you always have a very clear message, you have great data, it's very nuanced analysis, and you're very good at sort of sharing that message. And Gavin's even written an article about how to do a Lancet Commission, hasn't he? So, congratulations. I mean, my job is to say, of course, health policy and systems research has a tremendous amount to contribute to making these sort of policy prescriptions analyses a reality. And that is my job, so I will do that. But I genuinely believe that, because I think that when I read these types of analyses, but then when we heard from Dr. Viraj, Ms. Rosalind, about what was happening in their countries and their analyses, it is that question about how does global evidence and narratives like this, how are they translated at the country level, at the subnational level, into those realities? Because if you're honest, Sarah, I mean, you would accept that none of those countries that have reduced mortality by 50% in a short period, none of them followed this prescription, right? It's not like they went, oh yes, which are our 15 priorities, and then we'll have a modular approach, and they will do that, right? They didn't do that. So what you're doing is abstracting, and it's very helpful to show what's possible. But that's not necessarily the way that any country is actually going to do it. And I don't think that's your point, right? And so I think that's where health policy and systems research has a lot to offer, to actually understand, well, how might these type of aspirational goals be translated in a specific political economy, in a specific health system, in a specific society, in a specific political moment, right? And, whenever I am on a panel with Dr. Viraj, which is such a privilege, I mean, the papers that you have written about what explains Thailand's progress. Yes, they've scaled up coverage of essential interventions, but it hasn't been linear. There's been specific political moments where they've been able to harness knowledge and accelerated key reforms. So I think health policy and system research has a lot to offer there. And in countries like Thailand, they've used that, is to take this sort of global prescription and apply it to a very specific context and system. And that is where a field that is transdisciplinary can really be very helpful. I think other aspects that the field can contribute is on this question, and Dr. Viraj alluded to it, at national level prioritization. Our friends at the Centre for Global Development wrote a blog that was fairly critical, I suppose, about the Commission, and said, well, you're firstly, they were upset that you abandoned qualies, but also saying, well, no country is going to go 8+7 like this. There'll be, whatever the global evidence is, there'll be specific things in a country that are driving that prioritization process. I don't think that you're saying that should not happen at all, but I think, again, to do that prioritization, well, what is the local evidence? And what IHPP does in Thailand is very much contributing to that. And so that sort of national level prioritization process, to think, well, what should the modules be if you're going to take a modular approach in a specific country to reduce mortality, are very important. You showed your analyses and you said, well, in a lot of the African countries, it's mostly been on infectious disease. In a lot of, well, as you call the North Atlantic and East Asia, it's been on non-communicable diseases. As a lot of those countries are switching, it's not so easy to expect those same reductions, right? That's going to require tremendous systems change. I mean, chronic care service delivery in most countries, we just don't have it, right? And there are lessons from HIV that can be applied, but really to then reduce non-communicable diseases, which is what's going to be required, is very, very challenging, and that will need health systems research. And then the final thing I would add that health policy and systems research can contribute, and I've, as Dr. Viraj knows, I've worked quite a lot on social determinants in my career. The Commission's report is relatively agnostic or doesn't speak much about those broader settings. And again, all of those countries that had those tremendous reductions, there's a social story about what was happening in that country. Bangladesh's reduction, yes, at the community level, you're able to deliver better immunization, better prenatal care. But there's also a story about women's employment in the garment sector industry, which actually explains a lot of that reduction. I sort of teased Gavin, I said, isn't this still a little bit like selective primary healthcare on steroids? And he said, that's unfair, come on, 15 modules, all these interventions, being unfair. I said, I'm just teasing you. It's not, but the point is that, say, take child mortality reduction, which is where we have the most data for understanding what causes mortality reduction. And, generally most analyses, it goes back to say, well, 50% is better healthcare coverage reduction and 50% is essentially social determinants. And of course, you do call for tobacco taxation, but in general, understanding those factors in societal change that are driving changes in the social determinants, they're needed for direct mortality reduction, but they're also needed for people to be able to uptake the healthcare interventions which drive mortality reduction. And so thinking again about the health sector's role in contributing and driving those societal transformations to enable mortality reduction, and then also thinking how the health sector can work with other sectors to support those other factors in society. And then the last point, which links to, this is not going to happen, as you've said. If we have wars, if climate change goes on the trajectory it's going to happen, if we have pandemics. And I think pandemics you've described very well, but those other factors are also very related to the social determinants. So I do think, again, health policy and systems research can contribute on considering those aspects. So on the translation from the global to the national setting, on national level prioritization, and considering the social determinants. I think the health policy and systems research community has a lot to add, and I'd encourage everyone here to think then, this is such a nuanced analysis, there's so much here. The basic principle sets a very concrete aspiration, and so I hope we as a community can respond to that.
Very well said. Off to our fourth speaker, and then hopefully some time for question and answer. So Dr. Toshi, please come on up. From the Ministry of Health in Japan's perspective, the Commission says a lot of things about how development assistance needs to transition away from supporting countries and towards, supporting collective action and public goods. I'm wondering from the, government of Japan's perspective, how does this message resonate, or does it? If it doesn't, we'd want to hear why. And also, you were on the advisory committee for the Commission. I'm wondering if you can share some of the discussions from that committee and your view on how the report like this and related efforts can help strengthen the global health architecture, including this ongoing discourse around the Lusaka agenda. So, small things for you to discuss. Over to you.
Thank you, David, for big question. And I'm aware that we don't have too much time, so I do have some talking points, but I will not read it, and then to try to make it a short version. But first of all, I would like to thank Makimoto-san and JICA for organizing this timely event, and also appreciate the commissioner and the commission itself, and the presenters and the discussants for this wonderful 50 by 50, very forward-looking goal and the associated recommendations. So from the Japanese point of view, we are generally really supportive of this idea in terms of, basically all the recommendations. But you specifically asked about this so-called, future of kind of like international assistance or the global health initiative. So I can't represent all the, the advisory committee's discussions, but some of the discussions included that we need to kind of, rethink about how we contribute to global health through the global health architecture. We do have, for example, Japan contributed during the COVID-19. We contributed roughly about more than $5 billion through bilateral channel and multilateral channel. Multilateral channel included COVAX, COVID, the ACT Accelerator. We were the third largest donor to that framework. And also we have been contributing through the WHO, UNICEF, and all the global health initiatives. But we have to think about whether this kind of framework or the global health architecture as a whole is sustainable, especially after the COVID-19, when the global momentum is kind of waning. So we need to be thinking about the new kind of type of arrangement and architecture. We're not thinking that we need to suddenly merge all the global health initiatives. That's not practical. But I think this recommendation on this shift from this, direct country support and to focus more on the global public goods is something that we can think about as we go forward. I would like to defer points on the bilateral assistance recommendations to Makimoto-san, because she's from JICA and she needs to have some strong say on that. But we need to think ourselves that if we were to basically stop direct bilateral assistance to countries other than the most, the poorest countries, that could mean that we need to be stopping our bilateral assistance, for example, in many countries in Asia, for example, because they are not categorized as the poorest of the countries. So in the world. So we need to think about how we go about that bilateral piece. But in general, we are really we welcome this recommendation, and especially you asked about Lusaka, and Rosalind also mentioned about it. And just finally, I would like to share that the last year here in this particular venue, we convened G7 Health Ministers meeting. And in that G7 Health Ministers meeting, we supported this future of global health initiatives and signaled our support for that direction. And we are really glad that it culminated into this Lusaka agenda, which is to basically try to strengthen and synergize the existing global health initiatives to contribute to achieving universal health coverage. So we are really supportive of that agenda, and we want to follow through. And I think my time is up. Thank you.
Thank you very much. All right, we have about 10 minutes. Anyone who wants to linger longer can, but officially we'll be done 10 minutes. So I'll open it up for questions. Now, we don't have a roving mic, unfortunately, so probably you could either come up to this mic, probably the easiest, or if you can't make it there, you can just shout out and I'll repeat your question. But you can ask questions of the panelists, you can ask questions of the presenters, you can provide general comments or reflections, anything is open. So welcome to whoever wants to go first.
Hi. Thank you so much. Super exciting and great work. I really enjoyed the presentation and the comments. I'm Farhan Majid. I'm at USAID in DC, and I'm a health economist. I'm just going to be brief. I think I'm a little skeptical about the feasibility on the financing part. Just the Global Financing Facility just issued a report a few days ago where they showed that the government health spending actually is going down, and there has only been a modest growth in contrast to what we would expect. And the pandemic has another aspect too. It's not just a a health shock, but it's also a financing shock. And so that's another piece where I think is missing from the conversation, that what would they, there's an endogeneity with respect to financing from the mortality shocks, and that can completely change the whole game too. So I think there is we need more work on each country figuring it out on how to make this happen, but the financing piece needs some work. The other thing I just want to mention is in addition to the resource mobilization and the need for a broader conversation on taxation and how to raise those finances, there's also a conversation about cost efficiency and cost effectiveness. And I feel like there's not enough conversation on how do we institutionalize more cost-effective decision-making at the micro level across the board so that we can achieve that. This is really, I think, the most tangible thing we can all do is to work towards institutionalizing that across the board so that we do more with existing resources. Thank you.
Thanks very much. There are two questions online, Said. I don't know if you want to read them.
The first one is about the number 15. 15 for priority conditions. That was informed by any formula or just a researcher made it? That's the first question. And second one is in relation to the tobacco or making healthcare as a priority. how can we encourage more accountability among political leaders at national or international level to make decisions that fully benefit their people?
Okay, I'll respond on behalf of the Commission unless someone else wants to. So for the first question, the analytics team sat around and looked at a bunch of disease data and said, well, these things look like they kind of fit together. But we weren't starting from scratch either. I mean, there's big single diseases like HIV, TB, but I think conceptually closely related things like childhood cluster disease, it's all vaccine stuff. Strongly tobacco-related NCDs is basically a few cancers. Infection-related NCDs is like 3 or 4 key things like hepatitis B, HPV, and so on. And so they fit together from a kind of what sorts of interventions you might deploy towards them. And so it was really meant to link more towards a simple set of interventions that could address each of those things and interventions that have been used effectively for many years. So that's how that grouping was determined. It wasn't a magic number. I like 15 though. The second question on politics, I think this actually speaks to your point about the financing piece, because in the reality is that how much money goes to the Ministry of Health is a political choice in many countries, and so the biggest sort of solution for domestic resource mobilization is oftentimes mustering up the courage to increase taxes. Or other sorts of mechanisms that ask more of citizens, and that's not something many governments want to fight right now. Maybe from the Kenya perspective, you can remark on how the debt relief stuff unfolded. I mean, so these are really big political challenges. Even societies that want better health have to also kind of agree on how to do that. And so I agree, and that actually speaks to the social determinants piece. The political determinants of health, I guess, is maybe one of the biggest research items we could focus on in the future. So I very much agree. Other questions or comments? I think see that hand first, and then 2, 3.
Hi, everyone, and greetings to the panelists, and thank you very much for presentations. Were excellent. My name is Onomedi Sadolo. I come from Gavi, the Alliance. And I also, what wasn't touched on for me, and I think Ms. Rosalind started to speak to it, and I'd like to hear more from you from the Kenya experience, and as well, you touched on it, which is really programmatic sustainability. And so for someone like me sitting in the room, I do know from our support, I'd been in the UN as well before this, we all have invested significantly towards strengthening health systems, and yet the needle has barely shifted, to be honest. And listening to you, Ms. Rosalind, I started to hear the systems that the government was trying to put in place. For me, those would lead us to the pathway for sustainability. But in come 2050, where are we? Where do we think we're going to be from that program sustainability perspective? I would love to hear a bit more in that direction from you. Thank you.
Thank you. I think one of the biggest provisions of our facility improvement financing is that any appropriations in aid, any money collected by facilities is retained in the facilities. So that's the first bit. So the way our social health insurance fund works is when you walk into the facility and you're treated, then the hospital claims from the social health insurance and they are reimbursed. And if we go that direction and we ring fence the money, and I really want to say that has always been the problem. I had just written it here as part of my closing remarks, that we really, really need to be intentional about ring fencing money meant for health. It's usually the first to go. Money for roads, the budget for roads, at least in my country, it's never reduced. Money for water is never reduced. Money for everything else except health. And it's for the simple reason I have learned in the last 2 years being in this position that we cannot display health outcomes the way we display a pothole on a road. You can't say this road has 20 potholes and we need this amount of money to fix it. So you can't say our projection is that this could be the disease pattern for this year, and therefore we need it. So we always end up running to fund health as an emergency. And I think that's where we need to go first, ring fence the money meant for health and ensure that that budget is not turned. When you talk about sustainable health financing, when we talked about domestic resource mobilization, it means I pay for the service, but I pay a very subsidized amount. And I'll give you an illustration. So under Social Health Insurance Fund in Kenya, the lowest insurance premium paid by the people from the formal sector and the indigents, those who don't have any source of income, is 3,600 Kenya shillings. That's an equivalent of about $30. Yeah. So they pay that per year. But they benefit a lot much more. But the beauty of it is when they go to the facility nearest to them, apart from the capitation that the Social Health Insurance Fund pays back to the level 2 and level 3 facilities, when they go to a level 4 facility within their community, they are refunded. The facility is refunded. Now, because of the passing of the Facility Improvement Financing Act, all that money remains there. If it remains there, it means that it is used to improve health services in that area, and that is how we are ensuring sustainability.
We're right at 2, so I'm going to defer to Saida to make a couple of comments. Dr. Roach, did you want to say something first? Yeah.
From my understanding the ODA message 7, I understand that it is a balance between direct country support and global public goods. But Tochi, you said shifting from this to that. Oh. So what do you recommend? Sorry, I haven't read. You recommend to shift, right? To shift from this to more. Okay. So that the question is, I think the fiscal capacity in country after COVID, as the World Bank colleague said, there's not a rosy part. Then Wen Hui, you said you need to double increase government spending on health, maybe next to impossible. And 2% additional GDP on health. That's a big deal. Therefore, I think we need effective ODA. One plan, one budget, and one ME. And adhere to Lusaka declaration of commitment. So why you shift, or you just a good balance? David.
I think, though, the financing is always key. But in a way, the shocks that are happening are just accelerating us to where we have to get to anyway, or we have no choice, right? Because in a sense, at the peak of COVID, ODA for health got over 60 billion. But as we always say, healthcare as a sector is 9 trillion plus. And that doesn't include all the other inputs from the rest of society to health. And yet, often when we talk about global health, we're very focused on that 60 billion, which is now down to 40 billion, and will get down to probably to 30 or 25, what it's normally been very soon. And that distorts the discussion. I mean, money, health is funded by people's pockets, by governments. Now, the fiscal space analyses do look very grim, right? And that is true. So again, what this commission shows is what is possible if the right resources and inputs are aligned. And I think that's very helpful. But countries have found ways. I mean, Thailand is a very example. Even in a financial crisis, you rejected the advice and you went forward, right? So I think what is very important is what you're doing in Kenya, is that countries understand that whether it's in 2030 the cliff comes, whether given recent events the cliff is next year or in 2026, there is no other path but domestic financing. And so then it's that question of what choices are you making in that national prioritization to produce the most health, right? And ODA can only be a catalyst. It's not going to, there's no appetite, as far as I can see, to pay for addressing non-communicable diseases through ODA. And then even the sustainability of existing investments, is to Onome's point, is really under question. And we are going to be a very different world in 2050, but we're already going to be in a very different world by 2030.
So I know the time is up, but just finally, so just on this recommendation on the reset of UHC, I would call it upgrade of UHC rather than reset. Maybe this is just the communication issues, but because we want to follow through our aspiration towards achieving UHC and not just reset all the efforts. So I know that's not the intention of the Commission, but I just wanted to point that out. And just on that note, the Japanese government is now in collaboration with the WHO and the World Bank, primarily trying to set up this what is called UHC Knowledge Hub, which is to exactly kind of like elaborate on this kind of knowledge sharing discussions in Tokyo, hopefully next year. so that we can really, systematically share our knowledge and accumulate it so that we can really achieve UHC. So I just wanted to point that out and share with you that idea. Thanks.
Well, I'll hand it back over to Saida for closing remarks. And just before she says that, thank you all for participating in this discussion. I've learned a lot today. So thank you to the panelists, to the presenters as well.
Okay, so thank you very much for all the presenters, and thank you very much for the participants to have an active participation. This kind of dissemination or discussion the Lancet Commission is organizing in the world. Not only this time, but also in US or in other occasions, they are going to have this kind of discussion. And they also would like to have the country analysis as well. So our discussion is just started. We have to continue discussion. So thank you very much for participation for this time.